Okay, I guess we'll get started. I'm pleased to introduce today's speaker, Dr. Creasey. He's a professor in the Neurosurgery department at Stanford University. He served as chief of the Spinal Cord Injury Service at the VA in Palo Alto from 2008 to 2012. He has served on many boards, lots of publications. He's on the board of directors of the Rick Hansen Institute. He's on the editorial board of Sexuality and Disability. His interests are restoring function using technology and neural prosthesis. He has a long history of funding. His current funding is through the VA and the Department of Defense. And it's a pleasure to have him here, and look forward to his talk on restoration of function after spinal cord injury.
Thanks very much indeed, and thank you for inviting me. Brought some greetings from Stanford to Max, who used to be there, and others. And I was just delighted to be here because of the wealth of activity that you've been building here the last 10 or 15 years, and some fascinating work that's going on in a number of areas. So I'm really pleased to be here and learn all I can from what you're doing as well. And I picked this title, and it's a little ironic in a way that for most of recorded history, restoration of function after spinal cord injury was thought to be impossible. I think that, as you probably know, back in ancient Egypt, spinal cord injuries were recognized and thought to be an ailment not to be treated. And not much changed, really, for the next 4,500 years. This was a monograph published in London during the First World War. And regarding wounds of the vertebral column and the spinal cord, they also said these are nearly always fatal. So really, there was almost no progress for most of the history that we have, and certainly no chance of restoring function. And it was only during the Second World War that things started to change, largely through the efforts of Ludwig Guttmann in England and Donald Munro in this country. And the large number of injuries in the Second World War, which meant that they were clustered together and put into the same place, expecting that they would die. Certainly that was the case in Stoke Mandeville, that it was thought better for the morale of other patients if these patients were put in somewhere in the country, and Stoke Mandeville was a little-known hospital outside London where these patients were sent, and one doctor in particular was told, I'm sorry, you have to do this job. Somebody has to do it. They probably will all die. I'm sorry that we have to send you there. But Ludwig Guttmann, who had come out of Nazi Germany in the 30s as a neurosurgeon, and of course wasn't boarded or qualified in Britain as a neurosurgeon, and so he wasn't practicing neurosurgery, and he was given the task of looking after these spinal injury patients. And being interventionally minded, he was curious to see what could be done, of course, and he recognized that at that time the expectation was that most of these patients would die either of pressure sores or urinary tract infection. But that if you turn patients regularly, you might be able to prevent the pressure ulcers, and if you empty their bladder regularly, you might be able to prevent the urinary tract infection, which is what he started to do, and introduced intermittent catheterization at Stoke Mandeville. And so by the end of the Second World War, people were starting to survive. And then it was necessary to decide, what do we do now that we have these patients surviving? How can we prevent their complications? And one of my mentors who worked in the 50s and 60s said that even in those days, the maxim that they were taught was that spinal cord injuries should be treated superbly well or not at all. It wasn't a kindness to keep people alive with a lot of complications. And as time went on, then Guttmann and Munro's ideas were spread, so we got more comprehensive rehabilitation, the creation of spinal cord injury units and centers, and the comprehensive team approach that was able to think about improving people's quality of life by thinking about employment and education and different kinds of therapy, and what prospects there were for people to, if they were going to survive anything like normal length of life, then what kind of quality of life could they be offered? And so now I think we're only now getting towards this era when we can talk about restoring function. the question is perhaps what functions we should be thinking about restoring. And one principle is perhaps just to ask people themselves, people in wheelchairs. And you probably know Kim Anderson, who's not only a quadriplegic, but working in neuroscience and is now at the Miami project. And if you ask her what people in wheelchairs really want, her standard answer is everything. People want it all back. People want to be normal again. But when she says to them in some of the questionnaires she's done, if you can't have everything, what are the priorities? What would you like most? What would be the order in which you'd put the things that you want back? And then she's done, as you know, a number of studies of that, targeting the priorities of the spinal cord injured population themselves, and published this 10 years ago and has done a lot of work since. And so her description of what people want, if you look at what quadriplegics want, as you can see, the priority, as you'd expect, would be arm and hand function. And then given that, quadriplegics would be interested in sexual function, trunk stability, bladder bowel, control of autonomic dysreflexia, and then, as more distantly, walking, sensation, and managing chronic pain. Some studies show that chronic pain is rather higher than that, but this was what came out of her surveys for quadriplegics. And if you ask the similar questions of paraplegics, given that they have arm and hand function, then their next priority is sexual function, and then bowel and bladder, control of autonomic dysreflexia, and trunk stability, and then walking, pain, sensation, and arm and hand function. So while the wheelchair is such a potent symbol of disability, a lot of people who've been in a wheelchair a long time say, I can cope with the wheelchair. It's the incontinence or the infection or the hand function. As some patients say, if you can't use your legs, you can use a wheelchair. But if you can't use your hands, you can't use much at all. So I think this is worth bearing in mind when we're thinking about how to prioritize our research and what functions to work on, as well as marrying that, of course, with our own interests and background and skills and capabilities, which is where to focus our efforts. And historically, of course, there's a lot of ways in which function's been restored over the years, some of them stretching back a long time. And I'll just go through some of them fairly obvious, but see how can we pull these together to maximize the restoring of function and getting people back as near to everything as we can, or at least the priorities that people want. And of course, mechanical means go back throughout whatever time people have survived. Just giving people a wheelchair gives them back mobility, even if you can't walk. Giving them orthoses may allow them to stand and take some steps, even if it's not normal walking. And now we're moving on to other items like the exoskeletons that you see allow people to walk under power. So this is really just an extension of the mechanical engineering technology we have. I won't say a lot more about it because it's fairly obvious that disability requires a lot of technology. And most of that in the past has been mechanical engineering and mechanical technology. And that's the stuff of a lot of rehab. Surgical ways of restoring function, a variety of things we could think about, but one example I like is that of tendon transfers, where by moving the tendon from one insertion to another, you can give back a function that otherwise would be lost. So you can take a brachioradialis and detach it from the radius and then put it into the thumb flexor. And then you can have active thumb flexion. You can do the same with finger movements and give people back hand grasp that otherwise they would have lost for life. And so by relatively simple means, although they need to be done with skill, you can restore a function that wouldn't be present otherwise, even though you haven't changed the neurological condition. You've just rearranged what the person has to make it more functional. And that's not being practiced as widely as it might. I think that there's some studies done by one of our hand surgeons, Catherine Curtin, who's shown that a lot of this is not about the surgery or the science. It's really about the awareness, the attitudes, particularly attitudes of the caregivers, and depends who talks to the patient about the tendon transfers. And typically surgically minded people are more interventionally minded and more likely to consider this and propose this to patients. And so it partly depends on our knowledge and our enthusiasm for these techniques as to whether we propagate them to patients and make them known and give patients the option of having this done. But if it is done, it can transform hand function for some quadriplegics. chemical or pharmaceutical means, of course, is part of all of our lives in medicine. And as far as restoring function to people with spinal cord injury, there's not a lot, of course, we can do to improve somatic neurological function. Really can't do anything to give back motor function. We can get rid of some unwanted sensory function because chronic pain is such a significant issue in spinal cord injury. And likewise, we can get rid of some unwanted reflex activity and the spasticity that is a problem and sometimes an unsolved problem for people with spinal injury. But otherwise, we can't restore a lot of function. There's more to be done, perhaps, in the autonomic system. And those things are sometimes at least as troubling, if not more so, for people with spinal injury. So things like dealing with orthostatic hypotension or preventing autonomic dysreflexia, things like improving bowel function, depending a lot on medications, and even just dealing with the abnormal autonomic reflexes. And I mentioned autonomic dysreflexia, but some of the others, these are things that, again, it improves people's function even though we haven't really done anything for the neurological condition. It's an obvious and a commonplace thing that all of these things that we do make a difference to people's functionality. But of course the body uses not only chemical but also electrical control systems. We sometimes talk about neurohumoral control. And typically, of course, what we do pharmaceutically acts fairly slow and systemically, whereas the nervous system tends to act fairly fast and to have more local and more specific effects, although obviously there's interactions between the two systems, all our pharmaceutical agents often act on the nervous system and affect the either increase or decrease the likelihood of nerves firing, produce particular effects, and part of the industry is to try and make pharmaceuticals more targeted. And then, as somebody has described, action potentials as a means of targeted time delivery of chemicals or neurotransmitters. So these are obviously systems that work together, rather like an analog and a digital control system. And in normally, they work well together. We've talked about some ways in which we may get back some control, for example, of the bowel with pharmaceutical systems. The question is, can we restore some other functions, particularly functions normally under voluntary control, using electrical systems? And that's some of what I know you're doing here. And I've been interested in for a while and spent about 20 years up in Cleveland at the Functional Electrical Stimulation Center. And I think the electrical systems are usefully divided into what you might call control and modulation. I look on this as trying to take over control of the nervous system, typically pursued by engineers who like to control things and understand control systems and want to control nerves right down to the cell, the molecule, the ion channel, and understand exactly what's happening to the transfer of ions and whether you can start or stop action potentials. And so that's a very control-minded approach. At NIH had the Neural Control Laboratory years ago, and in Cleveland, Tom Mortimer started the Applied Neurocontrol Laboratory, wanting to apply that more clinically. And so that was part of the foundation of the Cleveland's work on functional electrical stimulation when Tom Mortimer came there in the late 60s, along with Hunter Peckham and Pat Crago. And they were all biomedical engineers. And in the early days of biomedical engineering, they founded that work on basically on the premise that if computers are so smart, as people thought in the 60s, if they're so smart, why can't we control nerves and muscles and movement and restore some function with them? Whereas neuromodulation, I think of as more as a collaboration with the nervous system. And typically it's a field driven more by physicians, often by neurosurgeons, and perhaps the prime example having been deep brain stimulation. And this is more a case of approaching the nervous system as a black box, and not necessarily understanding the mechanism, what's happening to the ion channels, what's happening at a cellular and a molecular level, but knowing that if you can do something like deep brain stimulation and make a significant clinical effect, even if we don't understand the mechanism, it's worth doing because of the huge clinical benefits we can provide to patients. And there's some parallels, again, between the fact that some of the approaches we use in neurocontrol and neuroprostheses act fairly fast, fairly local and fairly specific, whereas neuromodulation by electrical means, rather like chemical means, tends to be slower, systemic, and with more general effects. And so we might think of modulation both by chemical and by electrical means. So I think it's a distinction worth making, just so that we're able in our minds to think about mechanisms and where to apply each approach and how to combine them, sometimes using both. Just to focus a little bit on neurocontrol, which is really applied usually by using what come to be called neuroprostheses, a term that goes back, I think, again to the 60s and to Giles Brindley, who was funded by the Medical Research Council in London and set up the MRC's Neurological Prostheses Unit when he moved there from Cambridge and started work on a variety of different applications of neurological prostheses. And his work on the visual prosthesis led to NIH's neuroprosthesis program. There was a conference held in Washington, and he declined to come, so they phoned him up and had a speakerphone on the table, and he took part in the conference by speakerphone right after he'd done his first visual prosthesis implant. And that stimulated people to think that, why aren't we doing more of this? And so the NIH has had this neuroprosthesis program for many years, originally run by Terry Hambrecht, and that led to a lot of growth in the field because of the funding that they had provided. So really a prosthesis, of course, like a mechanical prosthesis, a neuroprosthesis is a substitute for damaged tissue, and if you have damage to the spinal cord injury, as in this case, then you can potentially create a device that replaces some of those functions, that can stimulate, in this case, the lower motor neurons to a muscle, and provided it's under the control of the individual with some way of getting signals of their intention, then this can become a voluntary pathway where the person can control the neuroprosthesis and thereby control muscles that otherwise were uncontrolled. And so the applications, as you're probably well aware of this, some of the first were actually the auditory prostheses. The sensory neuroprostheses led the field with stimulation of the auditory nerve to restore hearing, which is now a very successful application, well over 100,000 patients using this, and becoming fairly commonplace even for children and young people, even babies born with hearing loss, sometimes having these at a very early age. The work still going on visual prostheses, following on what Brindley did in the 60s, and that's sometimes called the holy grail of neuroprostheses because it's so difficult to restore visual sensation. But people working on it now, for example, at Second Sight in Southern California and other places, to try and give back some kind of sense of sight to people who are visually impaired. Not very much so far on touch, although there's been some work in Europe and in Cleveland on trying to restore touch. It's actually very challenging. The psychophysics of touch are not easy, and the kind of touch you give back is difficult to replicate our normal sensations. It may be unpleasant, it may be buzzing, it may be a tingling, and the kind of sophistication that we have in normal touch is very hard to replicate. You've probably seen some of the work where people have actually placed cuff electrodes on digital nerves and picked up sensations or signals from the touch sensors in the skin of the fingers and fed them back to the patient as sound. But feeding them back into the nervous system as a perception is much more difficult. There's some work in Edmonton on trying to feed them into the thalamus and trying to get signals into the nervous system that way. But very early in terms of providing any kind of useful sense of touch. Much more progress on motor neuroprostheses, and the earliest being breathing, and that goes back also to the 60s now. Bladder bowel section function largely stimulated by Brindley in England in the 70s, and then work in Cleveland on the upper limb and other places on the lower limb. So over the last 30 to 40 years, it's been pursued in those places. You're familiar, I expect, with William Glenn at Yale, who really pioneered the phrenic stimulator that's now commercialized by Avery, whereby you have an electrode on the phrenic nerve connected to a radio receiver, one on each side, and then an antenna outside the body connected to a battery-powered stimulator that transmits the signals through the skin and through the receiver onto the electrodes to stimulate the phrenic nerves and keep people breathing. And the other systems that I think are not available in this country, but some other systems available in Europe, for doing this. And this has, of course, been around for 30 to 40 years now, and some people have been using it for 20 years and more as their main method of breathing for high quadriplegia. And historically, it was done on the phrenic nerves either in the cervical area or sometimes by doing a thoracotomy, just to get to make sure you had all the tributaries of the phrenic nerves. But of course, not many, well, there aren't so many quadriplegics with this high level of injury anyway, and some of them are quite reluctant to have a thoracotomy. Some of their doctors are rather reluctant to do a bilateral thoracotomy in a high quadriplegic. So the numbers have been small for a long time. And more recently, the abdominal approach has been explored, and particularly when I was in the animal lab in Cleveland, there was work going on approaching the motor points of the diaphragm from the lower surface. If you look at the abdominal surface of the diaphragm, you can't, of course, see the phrenic nerves, but you can explore electrically and find where there are motor points where the phrenic nerve enters the diaphragm from above, and where the diaphragm is most sensitive to stimulation. And the advantage of this is it can be done by laparoscopy, so it's not so invasive. This is just a picture through the laparoscope using a small suction electrode applied to different points on the diaphragm. You can see little hickeys on the diaphragm where it's been applied for test stimulation to find the best point to stimulate. And then you can put in fine wire electrodes with a small barb into the undersurface of the diaphragm. This was, I think, originally just thought to be an experimental approach, and there was going to be a more definitive way of attaching the electrodes, but it's turned out that this seems to have been sufficient to last quite well. And putting in these fine wire coiled electrodes into the diaphragm with a barb on them, and then routing them above the liver and out through the skin, they've proved to be a kind of electrode that can last for quite a long time, and can produce, that's the other hemidiaphragm, can produce contraction of the diaphragm, typically a couple of electrodes each side for redundancy, and then running them out through the skin to an external stimulator. Ideally, of course, the stimulator would be put under the skin and radio controlled, but it just hasn't got to that point yet, and there hasn't been enough commercial demand to make a fully implantable system. But the advantages of it are that it's fairly minimally invasive, and so somebody like Christopher Reeve, who was the third person to get this, were willing to have this where he wasn't willing to have the more invasive surgery. He was concerned about damage to the phrenic nerves, and was convinced that this would risk his phrenic nerves less. So he had this procedure done, and he used to use it particularly when he was doing interviews or on television, so that he could dispense with the tracheostomy and appear more normal and not have the hissing of a ventilator. Of course, you still have to speak in time with the timing of the phrenic stimulation. And and some people do get rid of the tracheostomy, and some people keep it just as a backup. But it means that instead of carrying around a ventilator, you can carry around a small battery-powered stimulator. So it's portable. And by breathing through the mouth and nose, you can get back a better sense of smell, which contributes to taste. And so people like the convenience of it and the portability of it, and particularly like the fact that it's less invasive and can be done actually as an outpatient procedure, which makes it quite a lot cheaper. So it's currently being used it's FDA approved for ALS, being used in some high quadriplegics, and there's proposals to use it actually as an ICU intervention, so that for the short term in the intensive care unit, it might be something that could be done by laparoscopy, putting electrodes in the diaphragm and avoiding endotracheal tube or tracheostomy and the secretions and the infection and the complications of the tube for short-term use. So the idea being that if you need a short-term ventilation, you might put these fine wires into the diaphragm or even possibly into the neck, and then when the person recovers their ability to breathe spontaneously, you could just pull the wires out and just extract them by traction. I should just acknowledge perhaps that's Tony DeMarco, who developed the system, and Fred Frost, who was the head of the spinal unit in Cleveland at that time. But Tony has also worked quite a bit on muscles of expiration, the lower intercostal muscles and some of the abdominal muscles, and whether we might use them, because the previous system, of course, is entirely inspiration that's active, and then the expiration is just passive. But by activating the muscles of expiration, then it may be possible to produce other functions. And typically this is by using epidural electrodes placed at 2 or 3 levels on the dorsum of the dorsal surface of the dura here, and then routed under the skin to a radio receiver powered by radio transmission from an external simulator here. And then the person is given control of this device by just hitting a button, and can then stimulate muscles of expiration, particularly for coughing. And I may need to just operate this from here. See if we can get this to work. Not sure if this will play. We didn't plug in sound. I don't think we have.
Give us your best contact.
You probably can't hear that very well. I don't think we have the sound turned up, but I can play it later. There's a C4 quad who can just press a button and have a brief burst of stimulation that he can synchronize with closing the glottis and then coughing. And so he can cough by himself without having somebody else to do the quad coughing and the Heimlich type of maneuver that's used to help quadriplegics cough. And it's been shown now that you can quite substantially reduce upper respiratory and even lower respiratory tract infection and reduce attendant care. And so since respiratory infection is now probably the leading cause of death in spinal cord injury, and especially in high quadriplegia, the cause of frequent return to hospital, this potentially has quite a significant effect, not only on health but also on economics, if people can be more independent in clearing their own airway. I can play the videos later if there we go. Just moving on to other functions. Bladder function after spinal cord injury, which, as you know, is a source of, it used to be the main cause of death and is still one of the commonest causes of morbidity because of all the complications, not only to the lower tract, producing high pressure voiding, trabeculation, diverticular stones, infection, reflux, hydronephrosis, and used to produce quite a bit of renal failure and still does sometimes. So still somewhat unsolved problem, even after 70 years of spinal injury care. And this is where Brindley really made a big contribution. Really, the functions, of course, are ostensibly fairly simple, just to be able to empty the bladder when you want at a safe pressure and empty it fairly completely so that you get out the bacteria as well as the urine to reduce infection and stones, and then to be able to store it at safe low pressures for a reasonable length of time. And so essentially, you just want to be able to contract the bladder and relax the sphincter for emptying, or relax the bladder and contract the sphincter for storage. And apparently a simple system, but as you know, we all take longer to learn to control our bladder than we do to learn to walk. Babies are sometimes still in diapers when they're walking. So it does take a while to learn this, even for able-bodied children. And getting control of it electrically has been difficult. You're familiar with the anatomy and what goes wrong, of course, that typically when you've had a spinal cord injury, then you may have hyperreflexia, both of the somatic and the parasympathetic innervation of the bladder and of the sphincters. So typically you get co-contraction of the detrusor muscle of the bladder and the external urethral sphincter, and sometimes the internal urethral sphincter. And this co-contraction either means that you can't get the urine out, or can only get it out under high pressure with all those complications, or you force the urine to go the wrong way, back up to the kidneys, causing the reflux and hydronephrosis. So this has been difficult to restore. The approach that Brindley took was to stimulate the sacral nerves, typically S2, 3, and 4, by electrodes implanted in the spinal canal, in his case initially intradurally on the sacral anterior roots of S2, 3, and 4, to produce contraction. But as he and Tanago and other people knew, by stimulating S2, 3, and 4, you will stimulate both the parasympathetic and the somatic, and people thought this was a lost cause and wouldn't succeed if you caused contraction of both bladder and sphincter. What Tanago and Brindley both recognized was that you could use what's called post-stimulus voiding, that if you applied stimuli in short bursts, you could summate the contraction in the bladder, whereas the contraction of the external urethral sphincter, being striated muscle, came on and off rapidly with each burst. And so as you built up pressure in the bladder, there were times when you had bladder pressure without sphincter pressure, and you could have urine flow. So you'd have this intermittent flow of urine that wasn't how we normally void, but rats do and some other species do, and it's been shown over time this was both safe and effective. And so that was able to get urine out, but you're still left with the problem of hyperreflexia of the bladder because of this upper motor neuron lesion. And so over the course of time, a number of surgeons, and particularly urologists, started adding to the stimulation a sacral or sensory rhizotomy to abolish the hyperreflexia, both of the bladder and the sphincter, and combining that with the stimulation, so that the stimulation could be used for voiding in that post-stimulus pattern, and the rhizotomy would deal away with the hyperreflexia of the bladder, the hyperreflexia of the sphincter, and therefore the detrusor sphincter dysynergia, and therefore allow both continence and less obstructed voiding, and also do away with autonomic dysreflexia from the bladder. And so this combination was used quite a lot in Europe and other countries, used probably in about 20 countries now. We introduced it in this country in the 90s and took it through a multi-center trial, and this is the electrodes that were developed, typically placed extradurally or intradurally. This shows actually the lower end of the dura and the roots just after the dura ends. The dura has actually been opened here to do the rhizotomy intradurally, and then the electrodes can be placed either intra or extradurally, and these ones were placed extradurally, typically on S2, 3, and 4, or just 1 or 2 levels. And this just showed the places where the multi-center trial was done, and I was here when we did a few in Louisville in, I think, the late 90s. And we were able to get this approved and commercialized for a while in this country, but the company that distributed it then tried to do walking and went out of business. And so there isn't a US distributor at the moment, although it's still used in other countries. And it does produce has a lot of advantages, because you can produce bladder emptying on demand with low residual volumes and therefore low infection rates. The rhizotomy is what mainly contributes to reduced incontinence. And if you could void, of course, you don't need to use catheters so much. And the rhizotomy also allows you to get rid of anticholinergics and some of their side effects with the areflexic bladder. And the rhizotomy is really what gets rid of the autonomic dysreflexia. A few other things that this also produces: improved peristalsis, and sometimes defecation on demand. And especially by stimulating S2, you can produce penile erection in quite a number of patients. And reducing these complications does reduce the cost of care. There are disadvantages, of course. It's a substantial surgery to open the lower spine, and the side effects of rhizotomy made it less popular than it would have been, particularly among men, because of the loss of reflex erection and ejaculation. Even though they can be restored by other means, people were sometimes wary of losing these functions, and even though they're not always working well after a spinal cord injury. So I think that's limited the numbers. There's probably about 4,000 patients worldwide who've had this, and we're currently working on alternatives to the rhizotomy, electrical alternatives that might allow us to switch off the nerves instead of cutting them, and that looks promising in animal research. But this is just some of the early ones we did in this country, showing that the residual volumes were all over the map before, but we aim to get them all below 50 cc's of residual, and that, of course, is what helps to reduce the number of urinary tract infections, because if you get the urine out, you get the bacteria out. If you can void and be continent, then there's less need for urine collection devices. Some quadriplegics still will use a condom just for convenience, so that they can void even with the prosthesis into the condom and leg bag. There were one or two who did continue to use intermittent catheterization or a Foley out of these first couple of dozen patients we did in this country. And the fact that you've abolished the detrusor hyperreflexia means you can get rid of the anticholinergics. In most cases, this one patient who continued on actibutin lived in Seattle, and she took it to prevent sweating. She said it was cold enough in Seattle that she took the oxybutynin to stop sweating. Other reasons. And as I say, the autonomic dysreflexia related to bladder or bowel is abolished if you do the rhizotomy. In terms of what it does to bowel, the stimulation of the sacroparasympathetics can improve peristalsis and therefore reduce constipation by decreasing the transit time, and you can measure that the stool is softer and has more water in it. And in some patients, something like these numbers can actually produce defecation on demand with settings specifically for the bowel. You can program the device so that it can produce micturition without defecation, because people don't want, obviously, to defecate when they're emptying their bladder. But you can also program it to produce defecation in most patients. And in particular, what people appreciate is they don't have to spend so long sitting on the toilet and waiting for suppositories and laxatives and enemas to work. So they actually end up using fewer of these medications. And cutting down on the time of defecation, which can be substantial. And people have a more predictable defecation if they can have stool ready in the rectum to come out, even if it needs some help from a suppository or manual evacuation. And so people tended to use less manual evacuation or digital stimulation, less suppositories if they could use the stimulator. The interesting thing was getting the cost of care down in these various categories. This was a study that we did together with a life care planner who worked for insurance companies to work out the cost of care before and after the procedure, and showing that you could cut down the costs, particularly of bladder supplies and physician visits for people using this. And then if you amortize this against the cost of the implant, it took $35,000 to $40,000 for the procedure and the device to put it in. But then if the annual costs were less, after about 5 years, you broke even and then saved money compared to the traditional care that the patients had been using. This was an average of about a dozen patients that were studied. And so we were able to say to insurance companies that quite apart from any clinical benefit to the patient, if it saved the company insurance, it was in the interest of the payer to use this, because all the patients did actually live longer than 5 years. Just touching on neuroprosthesis for the upper limb. Some things you're probably familiar with from up the road, mainly in Cleveland, using implanted stimulators, typically with 8 or more channels. And you've seen these diagrams, I expect. They can be put in bilaterally with this stimulator under the skin in the location where a pacemaker would normally be put and controlled from external programmer and power supply that transmits power and control through the skin by radio. You can use myoelectric system recording electrodes for the patient to use contraction of the neck muscles to trigger this, or various other ways of triggering and controlling it. And this is the wiring diagram for one patient who had a bilateral system. I think it was 14 channels each side. And this is really the cheat sheet that's used during surgery to guide the surgeon in connecting up the wires to the different muscles listed here. And this is a patient. I'll see if we can just play this. This is a C5 complete patient who had that system shown. That was actually her wiring diagram. And so she has shoulder and biceps function, but then this just gave her back the sufficient control of the hands and wrist that she could do these bimanual tasks like folding a towel or feeding herself, brushing her hair, using a hairdryer, putting on makeup, other grooming methods like that. And really just converted a C5 injury into something that looked more like a C7 injury, a couple more segments of function to give back you can see both the wrist extension and some of the finger and thumb movement. Nothing like normal hand function, but as Bernal used to say in hand surgery, when you have nothing, a little means a lot. And so if you have no hand function, then just the ability to use fingers and thumb a little is worth it in itself. And you can hear the sound later if you like. I think I won't play the sound because she talks about it a little in this slide, but we won't be able to hear it. But she talks about how she'd just become a grandmother, and she was delighted to be able to hold her grandchildren and change their diapers or just groom and caress her grandchildren, and what a difference it made to her in terms of quality of life. Lower limb function I won't say a lot about because you do so much of that here, and I'm sure everybody's pretty well familiar with it. But again, it's using essentially the same implant, 2 of them in this case, 8 channels aside, total of 16 channels on the various muscles with these electrodes, either on the muscle itself or in some cases on the lower motor neuron. And so with 16 electrodes, you can produce a form of walking. With 8 electrodes, you can just stand up and sit down with a radio control. And you'll have seen, I'm sure, some of the videos of this and the kind of functional uses people put it to. Not commercially available. In fact, this was trying to commercialize this was what bankrupted one of the companies that was founded in Cleveland. But nevertheless, people have been able to use it, particularly to be able to stand up and sit down, which sometimes seems to be more useful than the ability to walk. And so people want to reach something out of a high cupboard, at a counter, transferring from bed to chair, getting around the house. Limited, short distance mobility, often in the house, standing up and working on a truck. This girl liked to sail and so would stand at the wheel using an ATM, and this girl actually got married using the system. She didn't try and camouflage it during the wedding, she just wore it as she walked down the aisle and said her vows. And so it turns out that standing, transferring, seems to be often more functional or more realistic than walking. To go any distance, people tend to get in a wheelchair, just as we use wheels if we're going any distance. And so that's where that stays as far as the lower limb's concerned. But I wanted to switch gear a little bit from the whole idea of this engineering control and taking over a part of the nervous system to what we can do with modulating it and trying to collaborate with the body rather than take it over. And taking perhaps the example of the bladder, where, as I mentioned, there are 2 main functions that we're aiming at, and there's been a lot of attempts to produce bladder emptying by neuromodulation over the last 30 or 40 years, largely without success. I think the coordination needed to contract the bladder and relax the sphincter has not really been achieved by attempting to modify normal function. It's been necessary to take over more specific functions, as you just saw. But there's been much more success in improving storage. And I think that you're familiar with the basic wiring diagram, particularly the sacral segments, the posterior roots, the anterior roots, both the somatic and parasympathetic, with the pelvic nerves, pudendal, the dorsal genital nerves, and other nerves to the lower limb. And I'm just showing the sensory ones in this case, because I think that a lot of sensory stimulation is what we're presuming is the main mechanism for neuromodulation, even though we don't really understand the black box thoroughly. But sensory stimulation to inhibit hyperreflexia is how it probably benefits us for bladder continence and other forms of neuromodulation. And of course you can apply that in a number of places. Some of the work that was originally done by Tanago in San Francisco and taken up and commercialized by Medtronic as the InterStim device was really through stimulating the sacral nerves in the sacral foramina by percutaneously inserted electrodes, stimulating mixed nerves in the sacral foramina. But Peters in Michigan is applying that to the pudendal nerve, and Craggs in London and others applied it to the dorsal penile or clitoral nerve, and a number of people in Europe applying it to the posterior tibial nerve. So it seems that stimulation of sensory fibers, particularly large sensory afferents, in a number of places is capable of producing reflex inhibition of the bladder and thereby improving continence. And so the work you're doing here by placing electrodes epidurally on the back of the spinal cord may well have similar function in order to neuromodulate the bladder rather than to try and take it over completely. And these are the kind of results seen, for example, with dorsal genital nerve stimulation, an electrode on the dorsum of the penis. If you apply continuous stimulation during a cystometrogram, a normal cystometrogram of somebody with a suprasacral spinal injury and hyperreflexic contractions at low volumes, if you apply this stimulation continuously while you're filling the bladder, you can fill it to much more like a normal volume, and you can reduce the reflex contraction of the bladder, and therefore improve continence and achieve more low-pressure storage. If you do that repeatedly, it's generally worth doing serial cystometrograms, because sometimes each time you do the cystometrogram, you get a little larger volume in the bladder, and so you need to do a number of controls. And as you'll see here, during neuromodulation, you can increase the bladder capacity, and it does remain elevated even after the application of neuromodulation. For a number of hours, there is a carryover effect that lasts at least for some hours. And so this is a way to look at that, both through the dorsal genital nerve, and this is some data showing that you get some improvement, and it actually gets better with each run of cystometrogram if you're using neuromodulation. And then the effect lasts a bit and then wears off after you stop neuromodulation. The same applied by sacral neuromodulation, in this case applied through the Brindley system with electrodes on the mixed nerves in the sacral spinal canal, again increasing bladder capacity. And similar studies being done on the pudendal and the postiotubercle nerve. It would be interesting to see what the electrodes that you're using here will do, just by comparison. Not only, of course, can you increase bladder capacity, you can inhibit the reflex contractions of the bladder if you apply the stimulation when you see a bladder contraction. And the interesting thing is that applying this dorsal penile nerve stimulation not only brings down the bladder pressure, it also brings down the blood pressure, because very often the blood pressure goes up with the bladder contraction as a form of autonomic dysreflexia. So it not only appears to be safe, it can actually be beneficial for reducing blood pressure connected with bladder contractions. And can also be used in that way, in that intermittent way. Instead of applying the stimulation continuously, as is done in this series of experiments, you apply it conditionally just when you see a bladder contraction. You can have a similar effects, and you don't then need to leave the stimulation on all the time, which is good for battery power and sometimes for convenience of the patient. So that those are different forms of neuromodulation, and this was a study I did with Michael Craggs in London, where using an implanted Brindley device with electrodes on the spinal nerves, we were able to compare continuous stimulation and intermittent stimulation with control periods of no stimulation and the period of oxybutynin use, so that it appeared that the stimulation by either format was comparable in terms of the volume that the patient was able to hold in the bladder, comparable to drug use and greater than that with neither drugs nor stimulation. This was over a period of a number of weeks when the patient recorded their bladder volume at catheterization. Coming on to limb function, in the interest of time, perhaps I won't play all the videos, but you'll be well familiar with the uses of deep brain stimulation for Parkinson's and for dystonia. Perhaps I will just show one of the ones that will play from here. But this is the kind of thing that I'm sure you're familiar with. Save the videos for later. But this is obviously transformed some patients' quality of life by applying this to Parkinson's and some other movement disorders by using deep brain stimulation. When we come on to spinal injury patients, there's less perhaps we can do with brain stimulation unless they have incomplete lesions. But looking at the spinal cord and peripheral nerves, this is, of course, the stuff of what you're doing here, and I look forward to learning more about this from you today. But briefly, the kind of things that have been used, as you probably know, are using some of the coordinated reflexes that exist, and some of the earliest work on getting people to walk after spinal injury were done by Louis Kral and others in Yugoslavia, where they would stimulate the common perineal nerve, produce a flexion of hip, knee, and ankle, and therefore this withdrawal reflex lifted the leg. And if you followed that by stimulating the quadriceps, you could extend the knee and put weight on it. for the stance phase of walking. And then you'd produce flexion withdrawal in the other side, flex the hip and the knee and the ankle, the aid of a walker, swing the body forward, and then stimulate knee extensors on the other side. So to produce a similar, simple form of stepping by alternating the flexion withdrawal and the extension of the knee. And that was really one of the earlier forms of walking for paraplegics, produced particularly by the Yugoslavians. Stimulation of sensory nerves in the lower limb, of course, as with sensory nerves elsewhere, it's possible to reduce spasticity in some patients. And this is the pendulum test you may know of, where by applying stimulation even to sensory nerves around the knee, for example, and not activating any muscles, you can nevertheless, in some patients, reduce the spasticity in the quadriceps. And this pendulum test consists in allowing the knee to drop and then just measuring the oscillations. And a knee where the muscles aren't spastic will swing freely like this for a number of cycles, whereas somebody who has a lot of spasticity around the knee will have more of a pattern like this as the knee gradually drops. And so it's one form of quantifying spasticity, which is otherwise difficult to do. And so that may be one mechanism of revealing function if we can cut down on spasticity by sensory stimulation. You may know of Stephen Seeger's work on rectal probe electroejaculation by putting an electrode in the rectum to produce seminal emission. A lot of people reported that when they'd had that done, they had a generalized reduction in spasticity for a number of hours or even days. And at one point he was proposing using rectal electrical stimulation as a generic treatment for spasticity. It's a little cumbersome and perhaps not so likely to be accepted, but just another example of inhibition of reflexes in general by sensory stimulation. And then, of course, spinal cord stimulation, which is what you're involved with here, and I won't say much more about that. But in summary, it appears that we can restore some specific functions by specific stimulation, particularly within the neuroprosthetic world. We may be able to restore more general functions by more general techniques like neuromodulation, either chemical or electrical. The questions are, can more general stimulation or less targeted stimulation, can we restore specific functions? In particular, can we facilitate automatic functions or pattern functions, stereotype functions like stepping, by non-specific stimulation, which is exactly the kind of thing that I think you're exploring, and can we produce these coordinated movements, and how targeted do we have to be in our stimulation, and what's the mechanism involved in doing that? In particular, too, can we facilitate voluntary functions by stimulation, and how do we have to target it, both in location and in stimulus parameters, to facilitate voluntary functions, which I think is such an intriguing area that you're working on. Bladder empty is one area, but of course limbs is the other area that is of interest here. Just before we finish, it would be remiss if I didn't say something about how we might restore function in the future using stem cells. Been a subject with a lot of interest, sometimes hype, and a lot of interest in California, where during the time that George Bush Jr. Set some limits on federal support for stem cell research, the Californian taxpayers voted to raise $3 billion to spend on stem cell research in California and committed to spending it over 10 years. So there's a budget of $300 million a year in California to spend on stem cell research. And we're just over halfway through and starting to see this coming from the lab being translated into the clinic. And just last week we put in a couple of applications on this. You probably know of the Geron trial, where Geron in Northern California used oligodendrocyte precursor cells. Originally planned a number of sites. It ended up that only 3 sites recruited subjects and only 5 patients who were actually recruited, these patients with complete thoracic injuries, and they had to receive the cells injected into the spinal cord within 14 days of the injury. Difficult to recruit and carry out this procedure in that tight time window when the patients had a lot of other things going on. But they were done. We did a couple out on the West Coast, and follow-up for the last couple of years has shown that, so as far as we can tell, this appeared to be safe, injecting these cells above and below the lesion. A couple of patients have had a bit more improvement in sensation than we would have expected by natural recovery, but you can't really hang your hat on such a small number of patients. And so we're just going to continue following those patients who are now 2 years out and fairly stable, partly for safety reasons. And as you probably know, Geron decided to discontinue this after spending a lot of money on 5 patients. They thought that they should spend their money elsewhere. But another company called Asterius has taken over their assets and their cells and their offices and their equipment, and is now planning to extend this trial to cervical spinal injury. And they're also following up the initial subjects from this trial. Still no safety issues, and they will be reporting later this year the results of that trial, and then we hope proceeding to, in the next trial, more of a phase 2 trial in quadriplegia. You may know of Stem Cells Inc., another California company that's using human neural stem cells in both complete and incomplete thoracic spinal cord injuries. And initially they were not able to get FDA approval in this country, so they started in Switzerland and did 9 subjects there with Armin Kurt. Then last year they received approval to do this in Canada, and they've done 2 patients there and now have approval in the States. Probably be doing 1 more subject, and then after doing 12 subjects, they'll present that data to the FDA. So far it appears safe, and some patients had, again, more sensation improvement than would have been expected, as much as 6 levels of sensory improvement. Again, it's hard to be completely sure what that means in small studies, but it appears safe, and now the proposal is to go forward and take this to the next step once these first 12 patients have been studied. You probably may know of work funded by the VA to set up a spinal cord injury consortium. It was initially done at Yale and UCSD with Jeffrey Kosis and Mark Jasinski, and now has been extended to a number of the other places in the University of California system. And this is taking 10-year funding from the VA and focusing on chronic spinal cord injury and possibly combination treatments, and trying to do more work in primates to get better preclinical data. A lot of this, of course, requires these networks that you're involved in. NACTIN is also hoping to start a trial of cellular treatments, and the Zurich study is the home of the EMSCI, and now the California Institute for Regenerative Medicine is setting up a network of 5 stem cell clinics around California. So I think in the future we might see these fields converging a bit. We might even think of hybrid neural interfaces, where really technically we should be able to both stimulate and record and create these neural interfaces between electronic systems and the nervous system. And some systems have been devised where you can deliver pharmaceutical agents along with the stimulation, perhaps growth factors to affect growth and migration of cells, and perhaps producing some guidance for guiding the cells as to where to grow. And also that opens up more possibilities for looking at the effects of activity on nerve structure and function, on what does this do about plasticity in the longer term, and how we can affect genetic expression and the growth and development of cells by activity and stimulation. And that's going to be particularly important if we put in cells that we train them to do what we want them to do. It's clearly standardizing the rehab and training the cells to produce the activities we want is going to be important. So we may see some convergence of stimulation and regeneration if we really want to produce much more sustained restoration of function. So thank you for your interest, and I'll be happy to discuss it further now or during the day.
I think we have time for 1 or 2 questions, quick questions that anybody has.
In your upper extremity example, I was impressed at how much function the lady really had, although not much useful finger function.
Right.
Has anyone tried combining tendon transfers with that?
Absolutely. Yes, it's a very good point, actually. And combining tendon transfers with stimulation really is a very synergistic thing to do, because stimulation provides more active muscles that can be used for tendon transfer. There are more available to the surgeon to transfer. And conversely, the transfers amplify or make the stimulation more useful. So typically doing the two together produces a lot more benefit, and a bigger toolbox for the hand surgeon to use the stimulated muscles, and the stimulation people to be able to take a muscle that wouldn't have normally had any function but put it somewhere useful. Yes, I think it deserves a lot more use. It's a good approach.
In one of your slides, you showed that when the neuromodulation was turned off, there was a period where it still had a bit of a lasting effect. I was wondering, do you see changes like that over time where the system can kind of adapt? And then, if so, I would imagine that devices might need some tweaking of the stimulus parameters as patients might change.
Yes. I don't think it's been studied very well over the long term. I mean, I think probably what's being done here is much more focused on what's the effect of repetitive stimulation, of practice, of really quite prolonged activity, and that may involve different mechanisms for producing more prolonged change, whether that involves more structural change and plasticity of a different kind. So I don't think it's really been looked at very well, and that's, I think, perhaps why you're in a very good position to look at that here.
Great, thank you very much, Graham.